we have different focuses on the patient, right? We have different areas with your HCAHPS scores and what's your quality metrics and what are outcomes, and like focus there on patients. But we're focused more at the end of the line, right? So there are decisions that get made up the stream, like all the way back up to when a supplier manufactures something that impact the patient. But instead of looking at it from a very macro view, we're looking micro. You're not looking at it. You're trying to take into account acuity scores and stuff like that to see like, okay, is this patient a train wreck, and the outcome is attributed to all these different compounding variables. But we're really not treating the system from a high level, looking at all the different variables, right? We're excluding some of them and expecting to find the answer in the bottom.
Without supplies, there's no surgery. Without products, there's no patient care. Welcome to Power Supply, the healthcare supply chain podcast focused on helping you navigate the intricacies of logistics, purchasing, contracting, and supplier relationships. Each episode, we speak with healthcare executives, supply chain leaders, and innovative entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the loading dock to strategic sourcing, from buyers to the C-suite, and across the enterprise, we tackle the real-life issues impacting the healthcare supply chain. Whether you're tuning in for conversation or inspiration, we're glad you're here. You're just in time to hear it from the source and stock up on insight. So sit back and plug into Power Supply.
This week on Power Supply, we speak with Ryan Bass, founder and CEO of Carrier. And we're going to be talking about patient positive and negative messaging as it comes to drip campaigns, and really connecting manufacturer and healthcare organizations with their consumer directly, Garry, and how to do that. What are some best practices, and what are the gaps in the industry today that can be addressed?
No, I'm looking forward to it, Justin, hearing from Ryan. This is a new arena that I haven't heard about. It's on some drip campaigns, the negative and the positive for the patient, how it ties into supply chain and, the manufacturer to the healthcare system to the ASC. I'm really curious to see how it all intertwines and where it goes from here. So looking forward to some knowledge, and had a little bit of time to talk with Ryan, and he seems to have some deep knowledge on this. So looking forward to today's episode.
All right, we're going to be right back after a short break with Ryan Bass, founder and CEO of Carrier.
I'm Hays Waldrop.
This is Garry Skinner.
And I'm Justin Poulin.
A production of 17 Studios. You're listening to Power Supply.
Joining us now is Ryan Bass, founder and CEO of Carrier. And Ryan, today we are going to be talking about patient positive and negative messaging with drip campaigns. And so this is obviously going to tie a lot into reimbursement. A lot of times we're all looking for cost savings in supply chain, but I will say there's been an increased focus on revenue generation, but then also the, cost loss, making sure that that isn't happening. And I think that ties very much into our conversation today. We have to look for efficiencies and funding, either through savings or prevention of loss, as well as new revenue. So thanks so much for coming on the show.
Awesome. Thanks for having me, Justin.
So Ryan, why don't you just talk about your background a little bit and maybe tell us something that you like to do as a hobby as well?
Yeah. So, starting out, I was a 2-time All-American goalkeeper in college. And so soccer is kind of my fun thing. As I've gotten more and more dad bod-esque through the years, the playing has slowed down a little bit. It's still something I like to get out and do. It gives you a little physical outlet and stuff where, I used to play it all the time. Now it's like once a week and, my body aches just the same. But, my background is healthcare IT. So I played in Kansas City, and then I started my, professional career at Cerner Corporation, now just purchased by Oracle. Through that, I got pushed into the quality reporting area. So doing regulatory reporting for hospitals within their acute care CMS submissions, or Center for Medicare and Medicaid Services. So I kind of drank from the alphabet soup bowl there with the healthcare side. So everything from IQR to OQR, IPFQR, I was in charge of the ECQM shift, which was electronic clinical quality measures back in 2016 for all clients that Cerner had. And so really went through those hospitals, selected their VTE, venous thrombotic embolisms, their stroke, your perinatal care, ED measures, and kind of started standardizing those where they had to select 4 from that. Met my now wife. She's a physician. So we've moved around a little bit, went to Southwest Florida for her clinical rotation years. That's where I learned the ambulatory side of the world. So again, alphabet soup of ACOs, MSSPs for accountable care organizations and Medicare shared savings plans, before moving to her residency hospital where I was the manager of IT governance and was in charge of kind of regulatory across the board. It was funny. I took that job with the last hospital because her residency was due to start July 1 and we had our first child July 2. So it was good timing. I had to make sure I had insurance. So I took that job so we were able to have the baby and not get the full force of the cost of it. So all that kind of led to me getting into the UDI space, or unique device identifiers, with getting the hospital compliant with 2015 CERT, which is Certified Electronic Health Record Technologies. And so having that free text capabilities being moved into discrete data, which led me into the medical device foyer of the FDA, and then, led me to ultimately create Carrier. So that's a quick overview of the background.
Nice. Well, I'll tell you, we've had a lot of people on this show with a cybersecurity or healthcare IT background already. You just threw out UDI, which has been a buzzword, and actually Safrao is our UDI expert at Power Supply on our expert series. And, I know we're going to kind of take a little bit of a left turn in a way from all of that and really talk about drip campaigns. And specifically, this is direct to the healthcare consumer. Can you tie that experience of yours in to this area of focus? It's obviously with the Affordable Care Act and accountable care organizations, that patient experience, those HCAHPS scores, everything really matters when it comes to the reimbursement model. And this is going back over a decade now.
Yeah. I mean, from my background, it really kind of ties into even more regulatory push since that, right? It's the 21st Century Cures Act and the adoption of the US CDI, or United States Core Data Interoperability Code Set. And it's really putting patient information in patient hands. So we went from this, 10 year ago billing focused platform, which, all EHRs really are, right? You look at their development and the rev cycles are way far and above everything else with patient scores. So now we're at a point where we're starting to see patients get more of their data and have more standardization, which actually allows for us to focus on this patient level communication that prior really didn't matter, right?
Ryan, I wanted to ask you too, as you take that to the next step. You mentioned you've seen both hospital systems and you've also been to the ambulatory surgery centers, the ASCs. The same, a little bit different. Are the ASCs a little bit behind? Are they ahead? How are you seeing this fall into place as well?
I mean, when we look at the hospitals versus ASCs, it really depends on the relationship, right? So are they owned by, do have a close relationship with their parent IDN? Or are they kind of want something that was purchased and is out there on its own and still has its own EHR that's independent and siloed? Are they completely integrated? I mean, I've talked to very prominent health systems where, they have a process to communicate to patients, but their process includes an ASC where a doctor is using their ASC that's not part. So they try to tell that doctor to go follow up with the patients because the cost comes back to the hospital system, but they don't want to intervene in that intermediate step to the patient. So I will say that ASCs in general are going to be a little bit behind within the tech usage of what's available and what can actually be there, because they're not looking to bring on a ton of cost, especially in the plastic surgery area. It depends on your reimbursement, right? If I'm not taking CMS monies, I don't really need to worry about a full-blown EHR. So it's kind of the bare necessities. But it's taking that IDN and integrating it from your GPO supply chain all the way down and kind of having one system and process in place.
So why don't you walk us through what that process should look like, right? Obviously the systems have some nuances to them, but they're all trying to execute a very similar process. So rather than talk about features of those systems, let's focus on the functionality and, what are the key steps and what does that look like?
Yeah. And I mean, I'll give you guys a good audio clip, so basically where we're at right now in healthcare, we have different focuses on the patient, right? We have different areas with your HCAHPS scores and what's your quality metrics and what are outcomes and like focus there on patients. But we're focused more at the end of the line, right? So there are decisions that get made up the stream, like all the way back up to when a supplier manufactures something that impact the patient. But instead of looking at it from a very macro view, we're looking micro. You're not looking at it. You're trying to take into account acuity scores and stuff like that to see like, okay, is this patient a train wreck and the outcome is attributed to all these different confounding variables? But we're really not treating the system from a high level, looking at all the different variables, right? We're excluding some of them and expecting to find the answer in the bottom. And so when we start looking at what the system has to be, it has to be patient centric. And like, that's important to all of us, right? Not only in supply chain, but like for us as patients. And so kind of the audio clip here is that like, we got to make supply chain care about the patient, not that they don't care about patients. And that's why that they're doing this, role in healthcare.
Yeah. You don't mean the people, you mean the process needs to care about them.
Correct. Because you get things like a recall hits a hospital and it's how quickly can I get this device off the shelf? If the metric was to the supply chain director, hey, you got to get them all off the shelf and notify the patients. Well, now they're going to care about notifying the patients and checking those boxes, right? Whereas today they're mainly focused on get it off the shelf, replace it, get the reimbursement if there was like a credit or something like that. But as far as if it's out the door, it's out of sight, out of mind. You know what I mean?
So Ryan, this kind of seems obvious in a way. And again, I know the Affordable Care Act has a big impact on placing our focus and emphasis on this. And we definitely have others that we've talked to about creating alert systems with patient safety in mind and getting more patient centric. But, the truth is, in the scenario that you just described, why haven't we already been doing this? Why isn't this something that's widely adopted and already baked into the process?
Yeah, I mean, your point exactly, right? So when we go in and talk to CIOs or that of health systems that we've engaged with, literally a CIO, first time we showed it to him, he goes, wait, why is this not what everybody already does? And the fact of the matter remains is that at the end of the day, back in 1998, when they started having tracking requirements on devices, those were really meant to be kind of like, I'll say, loose tracking requirements, right? And the problem with it is they said, okay, we're going to track all class 2 and class 3 devices. And so what that did is it shot the price up of how much it costs to actually like support that. So we started peeling it back and it was like, okay, all class 2 and class 3 devices, but you got to be in the body longer than a year. You got to be life supporting, and failure has to lead to serious injury or death if like you couldn't reach the patient due to a recall. So that cut the pie down, but still high cost, because every year you're putting new product out and you're putting hundreds of thousands of product out. You're trying to maintain a database plus update database, and it's all on paper, right? The UDI rule wasn't fully implemented or even at that point in process. You didn't have 2015 CERT adopted across health systems. You didn't have 21st Century Cures Act. All of these things didn't exist. So the best process we had was piece of paper, sticker, stamp.
Can you talk about some of those things, like the acts that have gone into place and everything? Just give us a timeline of how, through regulation and industry guidelines and best practices, that's all been shaped. I'm not necessarily the underlying why for each one, but maybe some real high hitting, high level, this is how we got here.
Yeah. And I mean, we had like, the Accountable Care Act, which, you touched on prior, which really was the push to having electronic medical records, right? And as I mentioned earlier, a lot of that was billing. Like if I'm giving a patient a Tylenol, I need to capture it. And so we moved from this having an electronic basis to how do we make it more actionable, right? And so that's where we adopted, 2015 CERT, which is Certified Electronic Health Record Technology. That's from the ONC, or the Office of the National Coordinator. And that includes, the standards of things that need to be discrete or documentable within the health system. But in that, even the process today is very slow, right? Every time you go to Congress, it is not a fast process. If it's getting put in the Federal Registry, like it is not something that's going to go through fast. So they adopted the USCDI, which is like a side process, which is the United States Core Data Interoperability, which starts to update and require those, but allows for changes more easily through that process without having to go through Congress. And so the adoption from meaningful use stage 2, modified, moving to stage 3, which was required for 2019, all health systems had to be compliant with 2015 CERT to be able to submit to that meaningful use stage 3, which is now called promoting interoperability. So there's really kind of parallel tracks of the hospital side of requirements and improvements to the EHR, or that electronic health record. And then concurrently, we have the FDA pushing through the UDI rule. And then what are those requirements on manufacturers, which then start to create a link between the two silos that have existed, in perpetuity in the past, right?
So what about transparency and obstacles to transparency? That's been a common theme in a lot of our podcasts, including, I think, the very last one that we recorded, Garry. But that transparency piece, I think some of this information, it's very natural to want to be able to communicate it, but depending on which side of the table you're on, you may want to communicate it differently, and you may want to be in control of how and what is communicated. Does that create an obstacle to creating this interoperable environment for getting directly to the patient? Is sometimes manufacturer and healthcare organization may not necessarily be aligned with what they want their customer to understand?
Yeah, I mean, I'll try to be diplomatic in the answer here, but it's one of those things of whoever wins the war controls history, right? So who's good, who's bad based upon who wins the battle. But really, at the end of the day, it's about being able to control the narrative and being able to kind of be capitalistic on it, right? So I always think of Fight Club. It's one of my favorite movies of all time. You have Edward Norton's narrator character talking about doing the recall in the car. And so they take the amount of out of court settlements by the probability of having those cars explode, multiply that, and then see if it's less than the cost of doing a recall. And if it is, you don't do a recall, you just settle out of court. And so there is this capitalistic mindset to it. And it's really it's kind of, a terrible idea when people's lives are at risk, right? But from the standpoint of business, a corporation doesn't care about life. The corporation cares about profits, and that's all their shareholders care about. So not to say that manufacturers are evil or bad in any such regard, but the thing is there's a capitalistic pressure on that, right? And the other side of it is there are confounding variables or things that could impact the outcome or the experience a patient had that's out of the control of the manufacturer's hands. So it's being able to control that narrative and data, which, keeping it lock and key and having gag orders on it doesn't let you do a lot of macro data analytics.
Well, Ryan, I'm gonna kind of capture some of the stuff you talked about and your historical presence of academia of what happened and where it got to. Ryan is impressive. I mean, for our listeners, he's not reading this. He's just rolling with it. So it's pretty impressive. But when you talk about how things have come to fruition and gotten to where they're at now, from the manufacturer side to the hospital supply side with supply chain and the cost. Is there an OpEx savings on the hospital side? Is there increased costs on the manufacturer side? Where is this pendulum swung as we've moved to where we are now in the future, if that makes sense?
Yeah, I mean, we've set up our own guidelines in the past. And by we, I mean, the industry at large. And all of those things have costs associated. So the quickest and easiest cost savings is just look at recalls, right? So it's a low frequency, high impact, but we also have a requirement to do them on paper, right? So CFR Title 21 literally outlines and says the three options you have for a recall are a first class letter, mailogram, or telegram. I didn't know you could send mailogram and telegrams anymore, but that's how you can comply with the code.
A mailogram. That's snail mail, right? Is that right?
Well, we had that same conversation with Guillermo Ramos. Basically when the recalls go, they're just all paper sent right out.
Wow.
Yeah. And so it's by design, right? And so that's where you also have this disjointed relationship. So I mentioned silos. I mentioned connecting the industry because the manufacturer sells to distributors, GPOs, IDNs, right? They don't sell to patients. Like it's very rarely that you're selling directly to the consumer. And so when they have a recall, their notice is to who bought from them, right? They don't know, quote unquote, who it is down the line. And so that's where the regulatory, like, kind of Molotov cocktail has started to happen, where we're starting to mix the FDA and CMS and ONC that primarily in the history have been, siloed and not really communicating, because the FDA doesn't have a stick over the hospitals, right? Like, what reimbursement do they have? It's got to be CMS that's mandating that, because all hospitals are chasing after the largest reimbursement, which is going to be CMS, and, complying to make sure that they get that good payment 2 years after the fact.
So when we talk about patient positive, bringing this back to drip campaigns and how that ties into this conversation, I think patient positive sounds really simple to me, right? You want them to report having a good experience. You want to send them lots of positive communication so that their experience is somewhat shaped about in the way that you're communicating with them. But what does that really look like when you say patient positive? And then we'll go to the other side of the spectrum and talk about some common mistakes that result in negative messaging. But let's start with the positive.
Yeah, I mean, I think the first thing before we talk about the positive aspect is just getting a response at all, right? Like, the EHRs have patient portals and my charts, and like, I'll be the first to raise my hand and say, I've never activated a patient portal until they told me, hey, the only way you'll get your COVID result is if you download my chart. Like, that was the first ever patient portal, and I've implemented and stood up and turned those on, and I'd never, accessed it, because it becomes this gibberish, right? You get notified and kind of spoken to in the industry lingo, and if you're not competent in that area, you don't understand. Like, I'm in a lucky position where my wife's a physician, so I get something and I just like show it to her, and it's like, what does this mean? Like, am I going to die next week? Is this something I need to worry about? And then she kind of breaks it down and gives it to me in layman's terms. But we have this kind of desire, I guess, to flaunt the lingo and use buzzwords and talk in this certain kind of language that we've adopted as the intelligent speak, and it leaves out most of the population. So when you do a recall and sound abatement foam, like on the Philips recall, what the hell is sound abatement foam? Where's that at on my device? And how is that impacting me? And where am I interacting with that? And so we really got to come back and look at it. How do we actually communicate this messaging to patients so that they will respond, right? It's really quick and easy. Somebody gets short into the stick or feels burned, they're quick to give you their opinion. But when you deliver something that people expect, it's not something that they're freely willing to do. So you have to really engage them multiple times to get that feedback.
Yeah. So it's really important that you get that response, right? But you don't always get it. And so how do we even know that if we were to do a drip campaign that was this patient positive endeavor, this effort, how do we know they're even looking at what response is one thing, but how do we know they're even paying attention?
Yeah. And it really comes down to like technology that's out there, right? So like, I don't want to harp on what we can do at Carrier, but like with our system, we can literally see when you open a message, click a link, answer the phone, when it rings, when it's processed. And then we put that into a historical record so that we can literally see the interactions from the patient standpoint. And so the integration of patient interaction with this like flow is even more than recalls, right? So like standards of care against devices that have, required metrics to be met to get the best outcome, things like IVC filters. UAB, the University of Alabama, Birmingham, did a study in 2018 that found that 55.3% of patients that received an IVC filter were lost to follow-up. Like, that's pretty ridiculous, right? But the thing is it falls into this chasm, because it's an outpatient procedure done in the inpatient unit with interventional radiology. There's no PSRs or any patient service representatives that are scheduled to follow up on, did they show up to an appointment? Did they not? And it falls back on nursing, which we have a shortage of when they're overworked. And so then you're trying to get a charge nurse or get a circulating nurse to like go through and follow up and call people. If they don't answer, then you're trying to send out physical mailings. And if they don't respond, it just becomes this kind of like wash my hands. But, that leads to huge, terrible patient outcomes where the pieces of the legs can break off and be pushed through your body. And it's so prevalent that Philips actually just got de novo clearance for a device to like cut them out of your vein from the scar tissue or calcification and remove them if they've been in there for a long time. But the problem is like Philips doesn't even make an IVC filter, right? They just see the opportunity of like, no one's pulling these devices and people are having issues. We got to make something.
Ryan, we just talked about, getting people to respond to these messages and these communications. And then how do we even know if they're reading them, if they aren't engaging? But I also know there's this increased emphasis on cybersecurity. We've had a couple of episodes, on that topic a couple of seasons ago. And I would think that if I'm a consumer, I can't tell you how often I open emails and I'm like, oh, this is spam. And everybody's so afraid they're going to click that link that steals their identity, right? That's boiling it all down. That's what people are worried about the most, and getting some sort of malware on their device. So is there a way to coach the customer or the patient to like receive those emails and know that they're not spam and not feel threatened by that communication? Is that a deterrent to being able to get this, patient positive messaging to them?
Well, it's really a combination of using existing structures that are already there that patients know about, and also being able to be HIPAA compliant, right? So you can't just call somebody up and say, hey, you have a recall on this device with this, software and update that's needed. Because if that person's significant other or somebody answers it and doesn't know they have it, then you're actually, violating HIPAA. So you have to have some kind of way to validate that they are who they are before you provide that information. So as I mentioned earlier with patient portals, like it's going to be like breaking down that barrier, like with people like me. It's giving a use case to someone like me that like is important to me and that I can understand to engage in those patient portals. Those activation rates are still, they're not historically low like they used to be. Like they're still improving. There's confounding variables of COVID and like I did that have been driving activation rates up. But now that people are starting to activate them, understand that they're a trusted source and a source of truth, it's driving people to those sources of truth to convey that information. So Carrier also was built on, let's not create another data silo. I don't want to have to get out there to, the 1 in 5 consumers in the US that might have a medical device of any type that, hey, we exist. And if you get a message, answer it from us, and then fight off the telecallers and everything else that scammers will use. But it's trying to say, okay, hospital X, you have a relationship with patient Y. Let's drive them to the understood communication point of the patient portal. And let's convey that information in a HIPAA secured environment that allows for exchange of information from both sides, right? And that's what's going to lead to patients trusting the system more and knowing where to go, as opposed to today being kind of healthcare illiterate.
All right. So let's we're coming up on the end here, but I want to talk about negative messaging. And obviously nobody means to send messaging out to the patients or their consumers in any industry that could be perceived as negative. And there's some pretty robust marketing teams out there that are trying to do their best to make sure that that doesn't happen. And we also know that people come from lots of different walks of life and different perspectives and different experiences. So sometimes you can be walking a little bit of a line there, but what are some real don'ts when it comes to communicating directly with the patient? Some obvious pitfalls that can happen with messaging and anything else around negative messaging that occurs to you, Ryan?
Well, I guess there's a couple different applications of the term negative messaging. So in the context you're using, it's about being succinct about the data, giving exact information, not giving a range of things, but giving precise information. I do think that there needs to be more negative messaging in the sense that when Allergan had a breast implant recall a few years ago, there's a huge, flurry in the market of who's impacted, who's not. And so we're good about, hey, let's send the positive message, you're positive, right, with this ailment. And so we need to message you, but we don't tell the people who aren't impacted not to worry, right? So we run into things where I have breast implants and I'm searching to figure out what I have, but I actually have, smooth as opposed to textured, but no one's giving me that peace of mind. So kind of in the foray of how do we communicate with patients, it needs to be looked at as not just communicating when there's a problem, but communicating when there's good news, or communicating when there's things to be proactive about, or giving, the ability for the system to actually like receive messaging back, right? It's one of those things. If I shoot out 1 million messages and I hit my target 1 million times, that's great. If no one's going to respond to me, if I'm going to respond and I have 10 people and I get 1 million messages back immediately, that's hung up phone lines. That's no one being able to respond. You lose control of that message. It goes to the news and the industry. And now all of a sudden you have a huge burden on your hands of trying to kind of do damage control. So it's really like being precise in the messaging, but doing a negative campaign as well to say you're not impacted. If anything changes, we will let you know, and really kind of keeping a calm in the area as a whole. One other confounding variable I'll add to that situation is, as manufacturers get bigger, you have your big players that everybody knows. They acquire, right? And so when they acquire, they don't keep the existing name of whatever it was. But in the age of paper cards, which we also provide electronic implant ID cards, but in the age of paper cards, you have McGann as your breast implant manufacturer. When Allergan does a recall and you pull up your McGann card, you're like, oh no, I'm fine. But really McGann was acquired, and it's actually part of that recall is rebranded as part of the new manufacturer. But there's no communication proactively to patients to say, hey, you actually got acquired. This is your new card. Here's the new manufacturer. And so all that becomes a price burden on the industry as well, which costs to the manufacturer get passed down to distributors, to hospitals, and ultimately to patients with large cell lymphoma, right?
Wow, that's huge. You're right. I was thinking positive and negative communication to the consumer being just the style of communication. But what you're really saying is positive communication, meaning you are impacted. Negative communication is also positive messaging to put you at ease. Negative, you are not impacted. And so would you say that the positive communication is far more common than the negative messaging that's getting out there? And so you have a lot of people that kind of like go into this crisis and spend a lot of time trying to figure out, should I be worried? Should I be worried? Should I be worried? And then because of a lot of the data changes in data and how that's communicated, it would also seem to me that they might be going down a bit of a rabbit hole that they can never solve on their own. Somebody almost has to do it for them.
Yeah, I mean, at that point, especially with implanted devices, you're cutting them open, right? If you lose your card and you can't pull it up on an X-ray to see markings, the only option is to replace it and do a revision. So and that also puts a cost and a burden on the health system, right? So you got a patient that's not impacted showing up, coming to your physician, taking up time slots to deal with other patients when there might be a 6-month wait to get in to see the doctor. And it's putting, costs that's pushing off other things that are more pressing because someone wasn't notified. Hey, you're okay. If you have something, then, you can reach out to us in this regard. And, I know we're coming to the end, but, we could go through adverse event reporting and everything else. That's a whole other ball of wax.
I'll bring you into our sister podcast, Transmission Control, which is really focused on infection prevention. And we've had a number of episodes, including our inaugural episode, talking about the MOD database and adverse event reporting. So just get ready. You're going to have an invite to another podcast on your hands so we can talk about that kind of communication and especially direct to the patient because we're so focused on that. I did want to ask you one other thing, though, as it relates to something you said earlier, get something out on the floor of Congress. It's going to take a long time. But are there some things that you'd like to see in this industry get addressed through regulation to sort of either create standardization or, advance requirements? Or do you think it's all there? The technology just hasn't caught up to assisting?
No, I mean, technology is far and above what's needed, right? I mean, it really comes down to a bunch of big fish in little ponds that don't want to play nice with one another. You come to a position where there is the ability for interoperability, right? And, I have a whole personal story where I knew Neil Patterson, one of the founders and CEO of Cerner, who passed away. I worked for his wife in college and knew Neil really well as well. And so, he had a story that he would tell people about his wife who had cancer at the time, where they were flying all over the country and he's the CEO of Cerner. And she has to carry around a tote bag full of all of her medical diagnosis papers because, there was an Epic system, a Meditech system, a Cerner system between wherever they went. And that interoperability didn't exist. And he was like, how can I be the CEO of one of the largest EMR companies in the world, and my wife has to carry paper everywhere? And you started to see Commonwealth come to fruition of having kind of standards, but then Epic then created Care Everywhere. And so you have two separate silos because they didn't want to interoperate in sense of, there's IP involved, there's potential, moats that could be crossed, and that could lead bad business, right? A hospital could easily transition to another EMR. And those EMRs are huge contracts, and they're meant to kind of keep you for life, right? It's very expensive to move across. So in the grand scheme of like keeping your business profitable and, continuing to climb, you have that kind of committed client base that's not going anywhere. And so it's really trying to get through the silos that exist and having people like Judy buy on. And, I call her out by name because, you can go out and read the stories where she was going to Congress saying that Wisconsin was going to lose a lot of jobs if interoperability became a thing. Once interoperability pushed through, she said Epic's, committed to supporting interoperability, but it's kind of one of those arm behind your back. I'm forced to say what I'm supposed to, right? And so we got to have more companies and more entrepreneurs really come to the battlefield and look at what are these different data silos that exist and how do we start to converge them together to allow for patients to really have control of their data. The 21st Century Cures Act says it's your data, but it doesn't really flow anywhere. So you have to really be a steward of that data. And so, I feel there are going to be a lot more companies, much like Carrier, as we grow in different areas within the health systems that will help to bring that integration together. It's just going to take third parties because the big guys won't sit together and say, let's just, direct connect to one another.
This has been a fantastic interview. And, I think we left some things on the table. We're going to have to bring you back. Yeah, I know Gary's got a few things in mind, but we can't give him all the information all at once. That's why we do weekly podcasts, Ryan. So you gave us an excellent interview today, lots to think about, and certainly around a conversation that we have not had as of yet. And I love the patient focus. Garry brings it up every episode
always
about how to be patient focused, but we really took a nice direction here about how to get right to the patients and their experience. And as we mentioned during the whole conversation, it's really tied to reimbursement now. So we're motivated in a whole new way. Thanks for coming on.
I appreciate it, guys. And, look forward to getting back on here and we can kind of dive down the next hour episode. I got plenty more that we could go down. So more than happy.
Sounds good, Ryan.
All right, that was Ryan Bass, founder and CEO of Carrier, and we're talking about patient positive and negative messaging and really the drip campaigns that are getting that information out to the patients. And honestly, even coming into this interview, I did not really understand the definition of patient positive and negative communications. Positive meaning you are impacted, negative meaning you're not impacted. At the same time, anytime you communicate directly with them, you want to make sure that you're maintaining a positive communication and not giving them maybe cause for concern unnecessarily, because who needs more stress in their life these days?
Exactly, Justin. This is another key arena that we haven't touched on in power supply. And for Ryan to come in and kind of tie it into the supply chain all the way to the patient-focused mission that I love to hear every day, I thought he brought the historical knowledge that he brought on board and what he shared and how it flows all the way down into revenue cycle all the way through. I thought he did a really good job. And, I think we should have him on board probably down the road again, too, because I want to talk about mergers and acquisitions, as you already know. I think he's got a lot of knowledge on this. So great interview.
Yeah, and that messaging and strategically for some of these larger organizations. So yeah, we'll absolutely have him back in a future season. As for this episode, that's going to do it. But as a reminder, you can help support Power Supply by subscribing on Apple, Amazon, or Google Podcasts. You can also find us on Stitcher, iHeartRadio, Spotify, or simply search for Power Supply on your favorite podcast application. Some of our episodes have bonus content, but you're not going to be able to get it unless you download the smartphone app for iPhone or Android. And while you're there downloading the app, we'd certainly appreciate a rating and a review, because your feedback is important to the show. And speaking of feedback, if you have a recommendation on a future guest or topic for the show, just send an email to info@powersupplymedia.net. On behalf of Garry and myself, thank you for listening to this week's episode of Power Supply.